Chapter 26, Respiratory Failure, which includes ARS, Acute Respiratory Failure, ARDS, Acute Respiratory Distress Syndrome, SARS, Severe Acute Respiratory Syndrome. Expected findings on page 162, Chapter 26 of ATI would include shortness of breath, dyspnea with or without exertion, orthopnea, which is difficulty breathing while lying flat, rapid, shallow breathing, cyanotic, mottled, dusky skin or mucous membranes, tachycardia, hypotension, substernal or suprasternal retractions, decreased SaO2 less than 90%, adventitious breath sounds, which includes wheezing and rales, cardiac arrhythmias, confusion, and lethargy. Acute respiratory failure expected findings would be dyspnea, orthopnea, cyanosis, pallor, hypoxemia, tachycardia, confusion, irritability or agitation, restlessness, and hypercarbia, which is high levels of carbon dioxide in the blood. Those are all for acute respiratory failure. The expected findings that I was reading was underneath the severe acute respiratory syndrome. Moving on then into acute respiratory distress syndrome would be dyspnea, bilateral non-cardiogenic pulmonary edema, crackles upon auscultation, reduced lung compliance, dense patchy bilateral pulmonary infiltrates, severe hypoxemia, despite administration of 100% oxygen. Laboratory tests for these would be ABGs to confirm and monitor ARF, ARDS, and SARS, PaO2 less than 60 mmHg and oxygen saturation of less than 90% on room air, hypoxemia, PaCO2 greater than 45 mmHg and pH less than 7.35, hypoxemia, and hypercarbia. Acute respiratory failure, you would want to do ABGs to confirm and monitor combined ventilatory and oxygenation failure, room air, PaO2 less than 60 mmHg, hypoxemic oxygenation failure, or PaCO2 of greater than 45 mmHg, in conjunction with a pH less than 7.35, hypercapnic ventilatory failure, and SaO2 of less than 90% in both cases. Diagnostic procedures would include chest x-ray. Results can include pulmonary edema, which is ARF and ARDS, cardiomegaly, ARF, diffuse infiltrates and white out or ground glass appearance, ARDS, infiltrate SARS. Nursing actions would be to assist with client positioning before and after the chest x-ray and communicate the results to the appropriate personnel in a timely manner. Electrocardiogram ECG to rule out cardiac involvement. Hemodynamic monitoring. Pulmonary capillary wedge pressure with ARDS is usually low or within the expected reference range of 4 to 12 mmHg. Continuous hemodynamic monitoring is important for fluid management. Nursing actions would be to monitor the ECG during placement of central venous pressure catheter and hemodynamic monitor, have resuscitation medications and equipment available, and monitor hemodynamic waveforms and readings, confirm catheter placement during a chest x-ray.